Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fowden, and Happy New Year if I've not seen you already. I think you're still allowed to say Happy New Year until the end of January, and particularly given that this is the first Grand Rounds of the calendar year. So welcome back to those of you who've been before, and welcome if you've never been before, and I hope you come back. Grand Rounds aims to give a broad review of different topics, and we welcome all professions. We've had people from, had members of the public, lay folk speaking, we've had scientists, and we have doctors, nurses, allied health professionals, the university, and the broader university, not just the medical school. And it's always nice to welcome people back. So when we've had people come and speak before, and it's not been so traumatic an experience that they come back to speak again. We had a in-person Grand Round at the end of last year, and I was speaking to Jonathan O'Riordan just before and after, and I was bemoaning the lack of people who are able to talk, and he said, I've got to talk, I could come and present. He spoke during the COVID pandemic on optic neuritis, no, something else, optic something else. He'll tell me, he'll correct me, I've forgotten already, which was a fantastic talk, and I'm pleased that he's going to talk about something quite different, although still in the neurological sphere. Concussion, traumatic brain injury, myths and foibles. Way back in, I think, 2016, we had a presentation from the orthopedic department about concussion and traumatic brain injury in rugby playing teenagers. And this brings us bang up to date with an extra 7 years or so of interest. I know Jonathan has a particular interest in this, and he'll no doubt tell you all about that. We hear a lot about concussion, recurrent concussions, head injuries, boxers, American football players, rugby players, people who hit their head a lot. So I'd be very interested to hear about Jonathan's experience in this, his expertise. If you have any questions, please put them in the chat. Keep your microphones muted in the interim and ask questions at the end. Jonathan, thanks very much for offering to present this first presentation of the year. Very much looking forward to it. And away you
go. Thanks for having me. So as a background, I'm a neurologist in Tayside, and I've been involved with rugby as a player, as a coach, as an administrator, as a supporter for about 50 years. And I've seen tens, if not hundreds, of patients who've been concussed on pitch side and also in the clinic. And I'm an advisor to the Association of British Neurologists on traumatic brain injury. So to begin with, we all have neonatal reflexes. So we were all born with a rooting and a sucking reflex. And the kids who had a rooting and sucking reflex in the past, they thrived in the litter, and their siblings who didn't, and they didn't pass on their genes. And we're all born with grasp reflexes. So here's a grasp reflex. You put your finger in. So that's another neonatal reflex. There's a withdrawal reflex. So that's a stimulus in the foot, and you get flexion of the hip, flexion of the knee, ankle dorsiflexion, and extension of the big toe when you withdraw. So the child who had a withdrawal reflex and their foot was beside the fire, they withdrew, shouted out to the mother rescued them, and they survived. The kid who didn't have the withdrawal reflex shouted out to the mother, but didn't take their foot away from the fire, burnt their feet, and their genes weren't passed on. There are other reflexes. There's a gallant reflex, a stepping reflex. And then there's a Moro reflex. So the Moro reflex is something that, again, has stood the test of time. So the child who was with their mother, perhaps in a tree, and the mother was trying to escape from a predator. And if they fell back, they would bring their arms around, and this combined with grasp reflexes would make the neonate hold on to their mother. So just see, this is just look what happens here with the Moro reflex. And the arms go up and around. Watch it again. And that's so that's a moral reflex. There's another reflex called the asymmetric tonic neck reflex, or fencer position. So on this one, the baby is lying on their back and they put their arm or put the head to the side, their arm will go to that side and they'll adopt a fencer position. So these reflexes present at birth, and they tend to go as time goes on. So after 3 months, the moral and stepping reflexes should disappear. Grasp reflex, tonic neck reflexes may last up to a year, but by and large, after 12 months, these reflexes have gone. So Ernst Moreau was born in Ljubljana in Austria-Hungary, and he made his way to Heidelberg, where he became professor of pediatric neurology. Now, there was no such person as fencer, but anybody who has done fencing at school or in university will be aware of various fencing positions and various fencing styles. But if you're not, you're more than likely will have heard of Romeo and Juliet, and Shakespeare was very aware of different fencing styles. So Romeo reports on Tybalt's style, and he says that he fights as you sing, he rests his minim, and 1, 2, and third in your bosom. And Mercutio says of Tybalt's style of fighting that his fiddlestick will make Tybalt dance. And at the time, there were two fighting schools, two fencing schools. One was Italian, one was Spanish. And in Shakespeare's time, people were very aware of these. One was more elegant and one was more barbarous. Mercutio fought in the Italian style, and it was an elegant style, but Tybalt fought in the Spanish style, a bit more creative, short stances, lots of moving, lots of angles, and as we know, Tybalt killed Mercutio. That's nothing to do with concussion. It's just an aside. But the important thing about these primitive reflexes is that in an adult neurological environment, they come back. So if anybody goes in a ward round with me, half the patients who are under my care on ward 23A will have some sort of primitive reflex. They might have a sucking or a rooting reflex. They might have a grasp reflex. So patients who develop a frontotemporal dementia, frontal stroke, brain tumor, will undoubtedly have rooting and a grasp reflex. People who've had a stroke, people who have problems in their corticospinal tracts, the pyramidal tracts, will have an extensor plantar response. So that's the withdrawal reflex that we heard earlier on. And people in trauma may exhibit primitive reflexes. This is a picture by André Brulé, and it's Un lecon clinique à la sapatrie. And it's in neurological terms quite a famous picture. So this is Charcot in the middle, and he has a patient who has a functional neurological problem. And Joseph Babinski is holding this patient up. And the other person of note is the chap with the apron, and that's Gilles de la Tourette. We also see primitive reflexes in concussive injuries. So this is a video from an NFL game, and the San Francisco 49ers are playing the LA Rams. And the 49ers are in white, cream, and red. And they went down to Los Angeles to play the Rams. And if you look at their wide receiver, who's number 11 here, and he gets tackled. And just observe posturing that he does at the tackle. So he's exhibiting a primitive reflex. We'll just see it again. Now, this video is from a French top 14 match. And the person of interest is the first center for Toulon. Toulon are in red. And this is a chap called Ma Nono. And Ma Nono played for the All Blacks. He's a Maori, 6'1", 17 stone, absolute animal. He's over 100 caps for the All Blacks, and he's won 2 World Cups. So he gets clobbered here. And watch his posturing. So he has a concussive head injury, and at this time he's exhibiting a motor reflex. Now the next one is from a match between Ireland and the All Blacks. So the Irish are in green and the All Blacks are all black. And what you want to look for is the number 13 for Ireland, who's the outside centre, Gary Ringrose, and he gets tackled. And this is Ringrose. Just watch it once more. So gets hit. So that's very straightforward, isn't it? And I don't think anyone who's watching this would miss that. So if you get a head injury or a knock and you're exhibiting this type of posturing, you're not waving to your colleagues saying that you're fine. You've exhibited a primitive reflex. It's not so straightforward because 6 months later, Ireland were playing Scotland in Murrayfield. So there's 67,500 people at the game. And perhaps millions, a number of millions watching on TV. So the number 1 team in the world versus the number 6 team in the world. Ireland had made 7 substitutions. You're allowed 7 substitutions. You can have an extra substitution if there is a head injury assessment, so you're not sure the person's concussed or not. You're allowed another substitution if there's a blood injury and another one for a front row. So same player, Ringrose, made a tackle and he got clobbered. And he exhibited a moral reflex in Murrayfield. And I remember at the game, just looking at Ringrose, the match was going on somewhere else. And he was just lying there with his arms over like that. And it was fairly similar to what happened against New Zealand. So what actually happened then was Ringrose goes off. And Ireland make a head injury assessment substitution. So in a match between 2 of the top teams in the world, watched by millions, Ireland made an 8th substitution in the match. They'd already made 7, and they shouldn't have made any substitutions because a head injury assessment is only allowed if there's uncertainty. But there shouldn't have been uncertainty because of what happened. So it's easy when I've shown you what I've shown you, but in real life, it's not so straightforward. And these are people who are fully aware of what may or may not be happening. So Ireland won the game as it happened, but that's neither here nor there. So concussion is a traumatic brain injury. And this brain injury happens because of a rapid acceleration. Well, that acceleration is almost always a negative acceleration. So you're going fast and you stop. And this acceleration is applied to the cranium, and then the force is dissipated. And the nature and the extent of what happens depend on the magnitude and any protective elements that may be there. So if you have head injury in sport, head injury in rugby, you may get laceration, hematoma, orbital injuries. Head injury to the cranium could be a fracture. Intracranially, you could get subdural, extradural, subarachnoid hemorrhages, contusion, intracranial hematomas. They're fairly severe problems, which thankfully in sport are extremely unusual. They happen in cycling if people aren't wearing a helmet. But we also see another type of head injury, and we call it concussion. I haven't classified traumatic brain injury into mild, moderate, severe, just because you might label concussion as mild, but it may not be. So the signs of concussion vary. One may get headache. The player may be dizzy, unsteady. They may complain of buzzing in the ears. There may be nausea, vomiting. There may be fatigue, drowsiness, blurring of vision. So they're fairly typical problems. There may be confusion or amnesia or seeing stars. So the person may not know which half they're in, who they're playing, what day it is. They may be slow to respond or dazed. Very unusual to have loss of consciousness, but I mean, obviously I've shown you 2 videos there that have that loss of consciousness, but more frequently there's a dazed look. And anybody who exhibits a primitive reflex has had a significant brain injury. The symptoms may evolve over hours and may evolve over 24, 48, 72 hours. And patients may experience concentration problems, memory problems, irritability, personality problems. They may have light sensitivity, phonosensitivity, difficulty sleeping, and they may develop behavioral problems. In kids, they may be different. So they may be listless, irritable, they may be unsteady, they may be crying excessively. Obviously, if they're vomiting or they're seizures, then that's a very significant event. But often it's more change in character. So what happens in a traumatic brain injury? And we're all biological creatures. And we're designed to move, we're designed to stretch, we're designed to stop, we're designed to start. So hopefully you can see this. So this is my wrist. And across my wrist, I've got a nerve called the median nerve. And that median nerve looks after my thenar eminence. And I have 3 muscles in my thenar eminence. I've got abductor pollicis, which is that movement. I press down here, I push it down. Flexor pollicis brevis, which is this movement, not this one, and opponens pollicis. Now, I can stretch my median nerve, and I can move it from side to side, and my thenar eminence still works. So I'm designed like this. I'm designed to move, I'm designed to bend, I'm designed to go back to normal. Now, what I'm not designed to do, so this is an elastic band, we pretend this is a nerve. I'm not designed to do that. So I'm designed to move, I'm designed to stretch, and I'm designed to recover in a reasonable way. If, however, this is an old band, I pull this band too much, and then I put it back, it's kind of warped slightly. So it hasn't gone back to normal. So this, what we're looking at on the screen, is an example of a neuron, an axon, from a rat. And the middle here is what it looks before before a force has been applied to this nerve. And then 2 types of force have been applied in this particular experiment. One is a stretching force and the other is a pressure force. And these nerves untangle and they warp and they bend, similar to my elastic band. And what's happening is that it's broken. So there's some fractures along the nerve and the nerve is damaged. And a number of things happen. So we break the axonal microtubules and you get undulations along the length of the axon. And that disrupts axonal transport, accumulation of proteins, so it damages the nerve. And then things happen, you get an influx of sodium and calcium, which are outside the cells and go in. And they disrupt the signaling in the cells, and they lead to depolymerization of the axonal cytoskeleton. And neurotransmitters, glutamate binds to NMDA, and you get neuronal depolarization. And then the system goes into overdrive, and you get a reverse sodium potassium pump. You get increased use of glucose, of ATP. So there's a massive increase initially of glucose metabolism. And this happens in the context of a diminished blood flow. And so there's a disparity between blood flow and glucose metabolism. And at this time, the person, we presume, is in a very vulnerable state to something else happening. Then you get a decreased metabolism. And later on, you'll get mitochondrial dysfunction, potentially cell death. And it can progress over 24, 48, 72 hours, which is what we see clinically. And it's not that this is an instant problem. It's something that evolves. So there's a metabolic dysregulation that happens in and around the time of the head injury. What happens to the person depends on where in the brain this problem might happen. So if you get a particular predilection to the frontal lobe, you may get behavioral, emotional problems, you may get speech problems. Parietal lobe, special senses, reading, writing. Occipital lobe, visual perception. Temporal lobe, language, memory problems. Cerebellum, balance, coordination. So a multitude of different things can happen for a head injury, and it will depend on where in the brain this thing has happened. And it takes time for people to recover. It can vary. And we kind of say between 2 and 4 weeks. And there's probably differences between males and females. Females seem to take longer to recover. And there's probably a range of factors which relate to that. Some may be the degree of impairment, some may relate to hormones, some may relate to the head-neck ratio and a greater degree of potential whiplash injury in the female. Some may also relate to the size of the neurons in a male versus the female. So back in the 90s, I was doing a lot of MRI research at the National Hospital in Queen Square. And we used to measure spinal cord diameter, and we needed control. So I was a control for my own stuff. And a colleague of mine was also a controller. My spinal cord diameter was 50% or so greater than hers. She was 5'0", 15 inches shorter than me. She could run the London Marathon. I could go around the golf course. But her spinal cord was smaller just because mine had to go further. And that's probably the case in male and female brains. Certainly in the rats, the neurons, the microtubules are greater in the male axon. And there is some pathological data from humans to suggest that the same may be the case. And if you break these, if you apply a stress force, either traction or compression, create undulation, so you fracture the microtubules, it seems to be that a similar degree of force is worse in the female. And that may explain some of the greater time for potential recovery. Now, does it matter? Well, probably does matter. That's Siobhan Catigan, who unfortunately, she passed away. She took her own life. And she probably had a number of concussive episodes. And it seems to be that her behaviour changed. and as whether or not she had any other severe brain problem, we don't know. But it's probable that her behavior was altered because of concussive episodes. The guy on the right is a chap called Ben Robinson, and he was 15 and he played rugby in Northern Ireland, and he suffered a relatively minor concussive episode in a match, played on, had another concussive episode, subsequently died. And he died from a condition called second impact syndrome. So that's exceptionally rare, but does happen, and happens to younger people. Back in the 40s, a chap called Schnichter described, I think, 6 patients or 6 kids who were playing American football, and they all developed a syndrome which was in keeping with cerebral edema following modest concussive injuries. And they all had a benign outcome, so they all survived. And he thought that this was a benign condition due to cerebral edema. Some 40 years later, there were reports of patients, again in NFL, American football, who had catastrophic cerebral edema in the context of head injury and a further head injury. And we know subsequently from pathological studies that there's uncontrolled cerebral edema that happens in a vulnerable brain. Seems to be younger people, so the people who seem to get this, mainly teenagers. The second episode and even the first episode may both be relatively minor, and you get this in an environment where there's a vulnerability, and it's uncontrolled cerebral regulation and cerebral edema. So it's an absolute utter catastrophe. Chap on the left is Muhammad Ali, and Ali, obviously one of the best boxers of all time, and he won gold in Rome for the USA in light heavyweight in 1960, and he was 3 times world heavyweight champion. I'm just giving my age away here, but in the early 70s, his fights were live on terrestrial TV in Ireland. So I remember watching the Thrill in Manila when he fought Smoking Joe Fraser. Fraser didn't get up after 14 rounds. That was a 15-round match. But Ali was fairly hammered during the fight. And 3 years later, down in Kinshasa, when he fought Big George Foreman in the Rumble in the Jungle, and he was again hammered. And he's one of his later fights was against Larry Holmes, and he clearly was extrapyramidal. He clearly had a Parkinson's syndrome, but in all probability he had a neurodegenerative disorder, of which Parkinson's was part of it, but he clearly was cognitively impaired. Person on the right is Fergus Slattery. So Slattery was one of the best wing forwards in Ireland in the 80s, and he played for a team called Black Rock. He also played for Leinster, played for Ireland, he played for the Barbarians, he played for the Lions, and sometimes he played 2 matches in a week. And his plight was the subject of a feature article by David Walsh in the Times a few months ago. And Colin Dorothy, who's his neurologist in Dublin, I worked with Colin in St. Vincent's, but undoubtedly Slattery's got a dementia, and it's thought that his time playing sport and suffering recurrent head injuries has played a part in that. Clearly, he hasn't had any PMs. Now, there's a condition called dementia pugilistica, and dementia pugilistica was described by Martland in 1928, and that was brain problem in boxers. And then about 30 years ago, Bennett Omalu, sorry, 20 years ago, did an autopsy on a chap called Mike Webster. So Webster, I can't remember, was he offensive linesman or anyway, an NFL Hall of Famer, played for the Pittsburgh Steelers. And he developed quite significant problems, and he died about age 50. And he had quite severe problems in his brain, which was labeled chronic traumatic encephalopathy. And this seems to be a tauopathy. You get neurofibrillary tangles, you get a progressive dementia. And after that, it was apparent that recurrent injuries may predispose to this developing. And these obviously are postmortems from 4 different people who have had this, who all played American football. And the thought was that the recurrent injuries predisposed to the subsequent development of a dementia. So they're not good things that you can get with head injuries. So that's what concussion is. Concussion is a traumatic brain injury, on the face of which one might think this is a rather mild thing. But you do get disruption of the physiology and anatomy. You can get a myriad of symptoms. The long-term effects of multiple concussions probably is not good. There seems to be a difference between the biological sexes, and in all probability, females suffer concussive injuries greater than males. There's this fear that I have in secondary school sport about second impact syndrome, in which the lack of an awareness that the player is being concussed and he plays on. I'm not certain about a head injury assessment in elite sport. So what do we do in Scotland in rugby and in football and any sport at present? If in doubt, you sit them out. And for the under 18s, there's a rest period, and then there's a graduated return to play. And essentially, if you've got a game on a Sunday, in all probability, that player won't be playing again for another 4 weeks. It's 3-4 weeks, but 23 days post-injury. And in the adults, it's slightly different. Instead of a 14-day rest period, it's a 7-day rest period, and then there's a quicker graduated return to play. And they're back in 2 weeks. The graduated return to play clearly depends on someone who can do this. And this isn't present in every environment. So you've got minimum rest period, you've got light exercise, walking, light jogging, swimming, cycling, no resistance. And then you've got some sport-specific exercise, and then you've got non-contact, and then you've got contact. And then they can return to play. So they need to be able to do this. If they can't do that, they go back to the previous step, and it goes on and on. And sometimes it could take a week, sometimes it could take 2 weeks, sometimes it could take 3 months. So they need to get past the next grade. Can we do anything else to mitigate against concussion? So identification, if in doubt, rest, keep them out. Head injury assessment in the elite game, I'm not certain. It only happens in the elite game, doesn't happen in the amateur game, so I'm not involved in this. There's probably a bit of confusion. I'd like to think not, because there's a lot of education that goes on at the moment. So any coach will have gone through many coaching sessions and this type of this isn't in the amateur game, but we see it all the time on TV. So we see it in the World Cup, we see it in the Heineken Cup games, we see it in the any of the professional games, the United Rugby Championship. And there might be a perception that this applies to the amateur game, but it doesn't. It's just an adult game. But if someone is identified as being concussed, then this doesn't happen. You don't wait another 10 or 15 minutes, see, are they better? They can go back on. So Gary Ringrose shouldn't have had this. He should have just come off, and Ireland shouldn't have made a substitution. Do helmets make a difference? Well, clearly in the world of cycling, I don't see anyone in intensive care following a cycle accident with terrible brain injuries who wears a helmet. Almost invariably, people I'm called to see haven't had a helmet on. So a helmet in cycling, stopping or dissipating that rapid deceleration once they hit the ground, is just, makes an enormous difference. But won't stop you from being concussed, but it'll stop you from having a very severe traumatic brain injury. This is a helmet for people who play a sport called hurling in Ireland. So every single kid and every adult who plays hurling now has to wear this. Back in the early 90s, nobody wore a helmet, but there were lots of head injuries, lots of skull fractures, lots of facial injuries. Probably won't stop concussive injuries, but it'll stop major injuries. So a dramatic improvement. Obviously, this particular helmet in the particular game that we showed earlier on, American football, doesn't stop the concussive injuries, doesn't stop the chronic traumatic encephalopathies. They seem to tackle differently. This is a head guard that's used in rugby, and there is some evidence from here that the pressure and the force and deceleration is reduced if you wear a head guard. I'm not aware of meaningful reports suggesting that this is replicated in the real world. So that's lab-based data, and you'll see that most players don't wear them. But you would think that the degree of force and the transmission of force may be slightly reduced, because there is a limit, and we're all designed to move, beyond which we get damage. This was developed by students in Loughborough University, and it's designed as a pitch side identification. I think it's limited. So you look at pupillary responses before the match. You're not sure a person has been concussed. You assess his pupillary responses at pitch side. You compare pre and post. And if they're the same, you're not sure, he's fine, goes back on. But obviously the pupillary responses won't affect frontal, parietal, temporal lobe. So it may be limited to certain types of impairment. And the other one which I've sort of struggled with over the years, so I've organized a number of tournaments over my time with from kids all over Scotland, so that from the borders, Edinburgh, Glasgow, Aberdeen, all coming to St Andrews. And we could have 500 kids running around, but we never had age weight brackets. If I was in Auckland, all the kids would have been weighed, and I've had age weight brackets. Now, in New Zealand, they've obviously got the South Sea Islanders, which genetically mature at a very early age to a very large size. So the Samoans, the Tongans, the Fijians, the Maoris genetically are very big and bigger than their Caucasian equivalents. Caucasians, particularly if they're South African, generally catch up. But when they're 10 or 12, the only people who are going to get injured are the little fellas. So they have an age weight bracket, and I struggled to engage anyone to have an age weight banding in Scottish rugby. But it could happen, and it might prevent some problems. Tackling is it's only at your P6, P7 now, but S1, S2 you'll see lots of size disparity. And finally, so just to this is if you're from Limerick, and there's probably only one person watching this from Limerick, and that's me. This is a very famous picture. So when I was under 15, we used to play junior cup rugby, and our school was across the road from a team called Garryowen, and Garryowen gave the name to a particular part in the sport, is kicking the ball up in the sky. That's called the Garryowen. And at the time, they had an out half, a number 10, who was very good at kicking. And he was very famous out half, and he was coming across the road to teach us kicking. So I was way back after training to kick. And this particular player played for Garryowen. He wasn't famous for that. He played for Ireland. He wasn't famous for that. He played for the Lions, but he wasn't famous for that either. He played for another team that wore red, and that was Munster. And he was famous for Munster because this particular day, Munster were playing the All Blacks. So because he didn't turn up, we cycled across town, and we managed to get ourselves into the ground and make our way to the pitch side. And this is a famous picture when Munster actually won 12-0. Christy Cantillon scores his try, and that's Tony Ward, who was our kicking coach. And you see that fella here, that's not me. I was the other end of the ground. But anyway, Munster won. So that's concussion and concussion awareness in a nutshell. I'll stop.
Jonathan, that's absolutely fascinating. And I think what you've done beautifully there is tell us what we see, the practicalities. And I think no one here would, everyone knows someone who's been concussed. Everyone knows of somebody who knows somebody who's seen a concussion. Yet you've told us very nicely about what may well be the pathological process of axonal stretching, etc. in there. I think Jamie McLean, when he spoke about rugby 7 years ago in the Ganachie, talked about age banding for kids in rugby, and how he was a strong advocate of that. And it's perhaps disappointing that we still haven't fully embraced that. I suspect Rebecca Wheater is going to talk a little bit about that, because she's very heavily embedded in the grassroots rugby game. But interesting how it is embedded elsewhere. I did wonder if you're going to talk about bike helmets, and you have, so it saved me the question. And it remains a very controversial thing, and there's some very, very vocal folk out there saying that go against wearing bike helmets. I'm certainly not one of those. I'm very much on your side, but we'll maybe come back to that once we've let Rebecca have a chat. Rebecca, for the benefit of the audience, just to introduce yourself and explain why you have expertise in this area.
Thank you, Tom, and thank you, Jonathan, for a great talk. So I'm a GP. I also referee rugby and deliver pitchside first aid, and I'm a first aid educator for World Rugby and for Scottish Rugby. So the first thing I'm going to do is to reassure you there's a lovely little law for referees, 6.5a, which says that we are the sole arbiter of law on the pitch. So if and when we see somebody go down and we think they're concussed because they've been dazed or they're not reacted, as the case may be, and the first aid is saying otherwise, I'd like to reassure you that we referees can overrule them. We can say, no, sorry, you're going off. And that message, if in doubt, sit them out, is very strong in Scottish rugby, certainly among match officials and among coaches. The weight banding, we keep we keep putting it on the agenda. We haven't got there yet with Scottish Rugby. I would like to see that happen. Jonathan, I've got a couple of questions, please. One is, I'm really interested in a functional assessment of brains after concussion. And following your talk with mention of sodium and calcium ions, I wonder about PGD PET scanning to assess injuries. So that's one question. And the other one is, I have had somebody in whom I thought they had a post-concussional syndrome, and I referred them to the neurologist at Tayside, and my referral got punted. So either I gave an absolutely terrible referral, it didn't have the requisite information in it, but I'd just like to sound you out about that, and that's putting you on the spot possibly.
Yeah, I can't comment on the PET scans, and when you would do them, you know. But so I can't answer that question because I don't know. In terms of traumatic brain injury in Tayside, Douglas Gentleman used to do a clinic for patients with traumatic brain injury. And so traditionally, Douglas saw these patients in the center, the CBIR, and we didn't. And when Douglas retired, that service sort of fell by the wayside, and it sort of I don't do the vetting. That's the other defense I'm going to make, but I think that's where the problem has been, that we don't have a neurorehabilitation service in Tayside. It's a shame, and we're not linked. Do you know, we're not part of the same department. We're separate. But Douglas kind of hid a lot of failures in the organization, I think. So I'm not sure. I can't comment on your patient or patients that were rejected.
Well, thank you for that, Jonathan. Just as a complete aside, I used to actually fence with Douglas Gentleman's daughter, Foyle and Sabre, so I appreciated those analogies. And I think if I were to have a case in future, I'd probably pick up the phone and say, now, Jonathan.
Well, that would be okay. You know,
okay.
That would be fine. Yeah.
Thank you very much.
And I've seen quite a number of people, you know, with concussion who would have been probably referred to me.
Thank you.
I've got my hand up. Can I speak?
You can.
Yes.
You're speaking.
Okay. Jonathan, this is a slightly personal question. I was on holiday with my son and he fell over and banged his head and had a generalized seizure, tonic, clonic and everything. Got a CT, he was normal, but should he ever play rugby? This is the question.
I don't know. I mean, he would have, so he probably had a provoked seizure. That's probably fair to say.
Whatever that is.
At the time of the insult. So that would have been part and parcel of the event. And did it take him time to recover afterwards?
About well, he woke up after about 10 minutes.
The event, yeah. But after that, was it?
But he was a bit obtunded for about an hour afterwards, and he was a bit confused, and but eventually got a CT, and it was normal, and but it was a very worrying thing to happen. And the question is, should he play rugby, or should he never play rugby?
Yeah, I don't think that event in itself would make him more prone to having more events or worse problems related to head injuries. Most people I'd see who had a very significant concussive injury probably don't play again. That's so if I see somebody in the clinic and their parents are with them and they've had one event and another event, it's generally recurrent or delayed recovery afterwards. They often don't. One event like that, it's rugby wasn't the cause of it, was it?
No, he slipped and fell and banged his head on quite hard, actually. But kind of spoiled the holiday.
So that would be an exceptional event. And I wouldn't, that event on its own, I wouldn't say is an exclusion for playing rugby.
Thank you for that.
But you might sort of think you had a very bad event, and I wouldn't like another, So there isn't a black and white answer, is there?
Thanks.
Jonathan, you you showed some American football footage with Brandon Ayuk having his posturing, and certainly having been a fan of American football for 30 years, you see a real change in how head injuries are dealt with on the football pitch, American football pitch. The blue tent is, everyone knows when watching, the player's gone to the blue tent. They know what that means. Concussion protocols. People are withdrawn much earlier. People sit out for much longer and people are in concussion protocol for days and weeks, etc. There seems to be it is a big change in American football. Yet in other sports, and this is just tagging on to Pete Ross's question here, that the big hits in New Zealand, I'm quoting his question here, they're still celebrated in the media with mixed messages of "smashed them, bro," or "the crown goes wild." How can we square off the apparent glory of these big hits with the damage they cause? And why do you think American football has made such big changes when rugby hasn't? When on the face of it, the American football players are wearing a huge amount of protective kit, and rugby players not so much. And I'm happy to be correct if they think that's wrong.
Yeah, I mean, I think I'm not certain about American football in terms of how, there's been perhaps $billion lawsuits in American football, so they've had to change. I think there was a perception in American football, you saw it's almost kamikaze in terms of their tackle, how they tackle. And having their helmet doesn't protect them from concussion. As Rebecca said, there's enormous awareness now in rugby at grassroots in terms of concussion, in terms of management, in terms of keeping players safe, delaying the time that the primary school kids have contact. So it's up to P6 before they will tackle properly. But the players are bigger, and the type of game that's being played now is different than I would have played. So I would have played a game that I could tackle anybody, but I probably wouldn't ever do an offensive tackle. So me tackling an 18-stone second row player, I have a hope in hell of tackling him, pushing him back. The only person who's going to get hurt there is me. And there was a phase in rugby where people often tackled upright, and you notice that there've been head-on heads. So an awful lot of head injuries were how you tackle, the perception that you need to have an offensive tackle, and an upright tackle. So the upright tackle is being dealt with. You're really penalized if you have an upright tackle. The offensive tackle is still a problem, I think, and size is a problem. And I think from a school point of view, I'm just sort of concerned that a lot of the schools will have elite players coaching, and it's a different game. The type of tackle. I think that you'll never see a fallback tackle because it loses ground, but safer.
Sorry, I lost my window for 2 seconds. There's a couple of questions in the chat box. We'll rattle through these. We've only got 2 or 3 minutes left. One of the questions is about heading the football. So move across from funny shaped balls to round balls and heading the ball. Any thoughts?
You can see that football has transformed itself. So if you look at the Premier League now, they all play almost like Barcelona. The people don't kick the ball out from their box. I'm not sure what it's like in Scotland football, but in general, the way football is played and the heading, you'll no longer have practice sessions with 10, 15 headers from the centre half, just heading the ball out. So heading is and the ball is different. The ball is lighter, so you don't get a very wet leather ball. So I think football has certainly improved, and the how you play the game has changed. So I think football will definitely be better.
Images in my head of Terry Butcher in the World Cup in
Yeah,
the 80s
yeah.
with playing on with his bandage and all the blood, etc. And that was a hell of a knock he took. But just simply heading the ball, I mean, I don't get involved in any of that business. Rod Mountain says, thank you so much for a fantastic presentation. Actually, that's heading. He's asked the heading question again. So Rod,
Yeah,
you've already
yeah.
answered that question.
I think that there's less of it.
Less of it is a good thing. Rachel Muir says, given the increased glucose up to intake, should concussed people get glucoboost?
Oh, I don't know that. That's just from, that's all laboratory data. So don't know. Not sure.
Excellent.
Good,
Right, we're coming to
a good point though.
Yeah, well, maybe that's an experiment for the future.
Yeah.
We've come to the way people need to get away from their afternoon clinics, etc. Jonathan, that's fantastic.
Thank you.
Really interesting talk. You had 81 people in the audience at the peak today, which just shows how interested people are in this kind of presentation, and a testament to your presentation skills that people want to come and listen. So I'm sorry we couldn't do it in person. I know you really wanted to, but at least take solace that 80 people did come to listen to you from around Tayside and further abroad.
Thank you very much.
Thank you. Thank you to Rebecca as well for coming along. I appreciate your expertise and your interest, and to everyone who asked a question. Next week, I have representation from this Chief Scientist office coming to speak. He's not telling me what he's going to talk about, but I'll find out and I'll send you all an email, and hopefully you'll be able to come along to that. I spent a portion of my Christmas holiday editing videos from last semester's Grand Rounds, so there are new videos uploaded to our YouTube channel, so please do go along to the YouTube channel and have a look at that. If you're watching them on YouTube right now, then you're ahead of the game. If you would like to get a certificate for watching this Grand Round, then I will share my screen, and you can, he says, you can scan this QR code. Here it is. And this QR code, oops, I'm sharing my entire screen there. That's a bit ridiculous. So there we go. So you can scan this QR code, and the QR code will take you to a video, a page where you can put in the details, and you'll get emailed a certificate for your CPD. Jonathan, thanks very much. Thanks for everyone for attending. I'll see you next week.
I know.